Welcome to Pulse&Pressors, where critical care gets crystal clear. Esmolol is an ultra-short-acting, beta-1 selective blocker designed for precise control of heart rate and blood pressure. Its rapid onset and fast offset make it ideal for unstable ICU patients, where you must act quickly and reverse quickly if needed. Its 9-to-1 beta-1 selectivity and ester linkage allow rapid hydrolysis by RBC esterases, making its clearance independent of liver and kidney function. With a 9-minute half-life, effects fade within minutes of stopping the infusion. By blocking beta-1 receptors, esmolol lowers heart rate, contractility, oxygen demand, and AV node conduction while blunting catecholamine surges. At high doses, limited beta-2 blockade can cause bronchospasm in sensitive patients. Use esmolol for acute aortic dissection, perioperative tachycardia, and hypertension. AFib with RVR, SVT, sympathetic storms, acute coronary syndrome with excessive tachycardia, selected hyperdynamic septic shock, and intracranial hemorrhage with severe hypertension and tachycardia. In aortic dissection, esmolol is first line. Reduce heart rate to less than 60 beats per minute before using vasodilators to lower rate of pressure change and decrease shear stress. It stabilizes type A dissections while awaiting surgery and is central to medical therapy in type B dissections. For type B dissections, target systolic blood pressure 100 to 120 millimeters of mercury and heart rate less than 60 beats per minute. Start esmolol, then add a vasodilator. Instead, XL shows TVAR plus optimal therapy improves long-term aortic outcomes versus medical therapy alone. Complicated type B requires TVAR plus blood pressure and heart rate control. Esmolol's value is speed, rapid titration, and rapid reversal. It reduces oxygen demand, tempers surges during intubation or surgery, and needs no hepatic or renal dose adjustment, making it ideal in multi-organ dysfunction. You may load with 500 to 1,000 micrograms per kilogram over 1 minute. Then start 50 micrograms per kilogram per minute and titrate every 5 minutes. Most patients need 50 to 200 micrograms per kilogram per minute. Above 200 micrograms per kilogram per minute, the risks of hypotension and bradycardia increase. Esmolol lowers heart rate, contractility, and blood pressure while reducing myocardial oxygen demand. Bronchospasm is rare at usual doses, but more likely at high rates. In decompensated heart failure, negative inotropy can drop cardiac output. Hypotension, bradycardia, heart block, and occasional bronchospasm are the main adverse effects. Peripheral infusions may cause pain. Abrupt discontinuation can cause rebound tachycardia, so taper if the patient is sensitive. Do not use esmolol in cardiogenic shock, severely decompensated heart failure, high-grade heart block without pacing, severe asthma or COPD flare, isolated cocaine-induced vasospasm, or pheochromocytoma before adequate alpha blockade. Esmolol provides fast, controlled heart rate reduction in AFib with RVR, often within 5 to 10 minutes. It is a strong alternative to diltiazem in borderline blood pressure patients. Once stable, transition to an oral beta blocker. In septic shock, early studies showed improved hemodynamics and a mortality signal in hyperdynamic, resuscitated patients. Later data confirm reliable heart rate control, but uncertain mortality benefit. Use only in carefully selected patients with persistent tachycardia. Candidates must be fully fluid resuscitated, MAP greater than or equal to 65 on stable vasopressors, hyperdynamic, not cold, with persistent heart rate greater than 100 to 110 beats per minute, and without severe RV failure or hypovolemia. Esmolol smooths perioperative sympathetic surges, limits ischemia risk, and offers tight control during intubation-extubation. Its rapid offset makes it safer than longer-acting agents in unstable postoperative patients. In ICH, blood pressure should be reduced to less than 140 millimeters of mercury. Nicardipine and clevidipine are first line. Esmolol is an alternative when heart rate control also matters. Avoid hypotension, which worsens cerebral perfusion. In sympathetic storms, esmolol controls extreme tachycardia. In thyroid storm, it's preferred when propranolol is risky. T4 to T3 blockade comes mainly from thionamides and steroids. In pheochromocytoma, beta block only after alpha blockade. Avoid pure beta block in isolated cocaine toxicity. Compared with metoprolol, labetalol, and propranolol, Esmolol stands out for its 9-minute half-life and precise IV titration. Ideal for unstable patients, where you need full control and instant reversibility. Prepare Esmolol at 10 milligrams per milliliter, 2.5 grams in 250 milliliters. Use a central line when possible. A good peripheral line is acceptable short-term. Monitor continuously and taper the dose in 25 to 50 micrograms per kilogram per minute steps when transitioning to oral therapy. Monitor telemetry and blood pressure closely. Aim for heart rate less than 60 in dissection and 80 to 94 in septic shock protocols. Use an arterial line when titrating quickly. Watch for hypotension, heart block, and bronchospasm. Check potassium periodically, as rare hyperkalemia can occur. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.